morning, everyone. We'll just start the session. I'm just waiting for Dr. Ajay to come, but I think he will join as soon as he gets free. So this session is primarily for anti-VEGF's evolving paradigms. Anti-VEGFs, we all know, were introduced decades back. And today, what I normally do is divide anti-VEGFs into conventional anti-VEGFs and newer anti-VEGFs. So conventional anti-VEGF agents or the first generation anti-VEGF agents are known to everyone. Those are ranibizumab and aflibercept and biosimilars, or even off-label Avastin also. But what has changed in recent times is availability of newer anti-VEGF agents, or what we call second generation anti-VEGF, because they have added one question of drying and durability. Because first generation anti-VEGF agents do work. There's no doubt that they are the gold standards, or they revolutionize the management of so many vascular diseases of the retina. But patients got fed up because of repeated visits. But these newer anti-VEGF agents, typified by brolucimab, aflibercept 8 milligram, and so many other agents, Vabysmo, they are coming up with the advantage that patients today you can extend the interval. So we'll in this session learn something about those things, and we are fortunate to have one international speaker from Germany, Dr. Chronopoulos, who will be joining us online. And then we'll have our own speakers, Dr. Saurav Luthra, Dr. Indu, as well as Dr. Sabyasachi Sengupta. And Ajay will be joining us. So aim of this session will be to see, can we extend? If we can extend the interval, can we increase the benefit to the patient and the family? Because today quality time is also very important. That patient has a lot of time, his repeated visit, repeated OCT consultations are reduced. So we'll begin with Dr. Saurav Luthra. Saurav is here. He will tell us about the gold standard anti-VEGF treatment choice.
Thank you, sir. Can I have my slides on that side?
Saurav, as you know, is the backbone of UK SOS and has been playing a very important role in organization of this conference also.
Thank you, sir. So I'll be just talking about the original ranibizumab that we know, which is so this talk is actually divided into sections, in which initially I'll just talk about a breakthrough, like how anti-VEGFs were a breakthrough in the management of retinal diseases almost 20 years back, and how ranibizumab became the gold standard anti-VEGF because of its efficacy. There's a lot of evidence on that. What is the innovator edge? How the patent molecule is supposed to be, the best. The pharmacoeconomics perspective, and what is the key takeaway. So pre-2006, we all know all these patients were turning blind, and there was a marked burden of blindness because of diseases like age-related macular degeneration, because all we had for these conditions was laser, photodynamic therapy, and surgical interventions, which were not the perfect treatments for this particular problem. And patients eventually lost vision. Then 2006 was a paradigm shift in the management of retinal diseases, and these were the landmark trials which established that. We all know these trials, and there was an improvement of about 7.2 letters, which was seen in Anchor, and about 11.3 letters, which was seen in the Marina trial. What has changed since then? So there has been a 46 to 72% reduction in blindness, and these are reports from various countries, where 50%, 51%, 46%, and 72% in the United States, based on these studies, where there is a reduction in blindness by that magnitude. With 18 years of extensive experience, the original ranibizumab is the gold standard treatment choice because of its efficacy, because of the innovator edge, and the pharmacoeconomics. Original ranibizumab is supported by a large amount of clinical evidence and patient experience. It has the largest number of approved indications. It has the largest number of clinical trials, so 6 approved indications, more than 7 years of long-term data available, more than 22,000 patients included in extensive clinical trials, and more than 73,000 patient years from continued post-marketing real-world data and pharmacovigilance studies. So this has the largest amount of patient data for any of the drugs in retina today. So the wealth of evidence of original ranibizumab in neovascular AMD also came from the View 1, View 2 trials, and also I won't go into the details of these trials, and of course the CAT trial. Also there was the rival study, which concluded that the study found no significant difference between ranibizumab and aflibercept in the development of macular atrophy in neovascular AMD patients, and they achieved similar number of injections, visual acuity and retinal thickness improvements over 24 months using a treat and extend regimen for neovascular AMD. Also we had the trial, the Rise and Ride trial, where ranibizumab showed visual acuity improvement by month 4 and improvements were maintained through 54 months, and protocol I, in which ranibizumab alone or combined with laser showed visual acuity improvement in month 12 compared with laser alone. Ranibizumab with deferring laser for more than 24 weeks showed better visual acuity outcomes than ranibizumab with prompt laser, and which was maintained through 36 months. And then we had the Restore study, which showed that ranibizumab alone or combined with laser showed significant improvement in BCVA at month 12 compared with laser alone, maintained through 36 months, maintained with fewer ranibizumab injections. Then we also have the Brighter and the Crystal studies. So these also conclusively proved that ranibizumab was the gold standard anti-VEGF. So the wealth of real-world evidence of original ranibizumab is from the Luminous study, which was the largest prospective observational study in medical retina. It was a global 5-year multi-center observational study across all approved indications to evaluate the long-term effectiveness, safety and treatment patterns associated with the ranibizumab 0.5 milligrams in routine clinical practice, with more than 30,000 patients over 42 countries and 488 sites. Ranibizumab showed a consistent visual acuity outcomes across approved indications. In neovascular AMD, there was an improvement of 6.8 to 12.3 mean BCVA gains in ETDRS letters. In DME, 6.8 to 10.3. In BRVO, 14.3 to 18.3 gain in letters. And in CRVO, 12.1 to 16.9 gain in BCVA letters, and in macular CNV, 13.8 BCVA gains, and other CNVs 11 ETDRS letters of BCVA gain. So early visual acuity gains with ranibizumab are maintained long term. This was also seen in the studies. So ranibizumab improved functional areas beyond those related to vision alone, and in which we had this quality questionnaire, the NEI, the National Eye Institute VFQ 25 score, where the role difficulty, social functioning, dependency, driving, color vision, peripheral vision and mental health all showed improvement. So these were the areas beyond vision which were improved. So with extensive experience of 18 years, the original ranibizumab is the gold standard. The innovator edge, so now another point to consider is how similar are biosimilars with innovators? Are biosimilars manufactured right? How stringent is the approval pathway of biosimilars? Are the current biosimilars interchangeable? So if we just go into the manufacturing process, how biologics are produced, it is quite comprehensive and has multiple steps and leading to higher risk of errors, if not done properly. So we have to know whether the biosimilars are being manufactured correctly, because what they do is reverse engineering. So they begin with limited knowledge of the reference product, and after reverse engineering, the DNA sequence is based on the primary protein sequence of the reference drug, which is available in the public domain. How similar are biosimilars with innovators? How stringent is the approval pathway? So we know that the approval of non-innovator biotherapeutics in India is not very stringent. The FDA has adopted a totality of evidence approach to the approval of biosimilars, in which multiple lines of evidence are integrated to determine biosimilarity by the reduction of residual uncertainty. A simpler regulatory pathway in India might result in misses, And this is where clinical studies for approvals are missing, in India, whereas in the, in the West, in the FDA and the European agencies, they have much more stringent controls of manufacturing of biosimilars. So is it the same globally? No, there are no fixed guidelines globally regarding their approval. Guidelines are constantly evolving as technology grows. However, fundamentals of the guidelines across the world are the following: analytical studies to demonstrate high biosimilarity, animal studies for toxicity assessment, clinical study to assess safety, efficacy and immunogenicity compared to the reference biologic. There are multiple steps to assess above 3 described points, and each country has a committee which decides the next step of evidence on the basis of the strength of similarity in the previous step. So does a biosimilar need to go through separate approval for each indication? No. It can be approved for all the indications for which the reference biologic is being used, provided analytical, scientific and clinical data of similarity are robust on the tested indications. The third point to consider, which is the third question, is are the current biosimilars interchangeable? So biosimilarity and interchangeability are two things. So in biosimilarity, a biological product that is highly similar with no clinically meaningful differences is a biosimilar. Whereas interchangeability, you have to see whether one biosimilar, if it's being given to a patient and you can give another biosimilar of a different brand, and whether it's interchangeable. So that is where another problem arises, because nowadays we know there is an array of biosimilars available even for ranibizumab. So to consider the cost of comorbidities with neovascular AMD and DME, so neovascular AMD is associated with an increase in age, which is in turn associated with multiple comorbidities. DME is associated with chronic diabetes mellitus, and diabetes we know is associated with hypertension, obesity and high cholesterol as a part of the metabolic syndrome. And management of these associated comorbidities also has economic implications for the patients. Despite high prevalence and detrimental impact on quality of life, many patients cannot access or adhere to treatment. Reasons for not adherence to therapy are excessive treatment visits, difficulty in attending, expense, pain, discomfort, treatment is not beneficial, or other more severe medical conditions. Cost is another critical barrier, where the cost of the drug, the cost of the procedure, cost of diagnosis, cost of travel and stay, cost of attendance, cost of absenteeism. 37.5% of patients with DME do not comply due to non-affordability. In AMD, about 30% patients do not comply, and in our view, about 25.3% patients do not comply due to non-affordability. So sometimes indirect costs can even exceed direct treatment related costs, which include a multitude of things. So cost may also vary across regimens and drug, whether it is being used PRN, treat and extend, monthly injections, 12-weekly dosing. Hence, number of injections, treatment regimen, disease control may also impact cost. Anti-VEGFs have potential to improve visual outcomes. Innovative treatments like anti-VEGFs have the potential to improve visual outcomes. However, in a self-pay market like India, the high cost of anti-VEGFs and lack of insurance coverage are major roadblocks. Insufficient use of recommended injection regimen leads to suboptimal visual outcomes in the real-world scenario. Indian anti-VEGF market is fragmented with innovator, biosimilar and off-label options, and thus creates a dilemma amongst the healthcare providers to choose an apt choice for their patients. There is a need for a cost calculator, considering both direct and indirect costs to facilitate evidence-based decision-making. And in the 22nd EURETINA Congress at Hamburg, this cost calculator was described, where it's a tool as simple as Optimize cost calculator, which will facilitate evidence-based decision-making in 4 easy steps: patient inputs, molecule inputs, treatment inputs, and then we get the dynamic results for various disease indications. And in that the outcome is out-of-pocket costs we can get easy comparison between various treatments, outcomes after considering PSPs and insurance coverage, and this assists the healthcare providers to facilitate evidence-based decision making. So this is a snapshot of the optimized cost calculator, which is available online. And again, you can see here that with ranibizumab, the cost is coming to about 27,833, whereas for the biosimilar it's about 24,833, and for bevacizumab it is cheaper at 19,500, but of course with the attendant risks of being an off-label drug, and the spurious drug which we saw created a lot of issues in the past. So to conclude, with innovators and originals, there is optimum risk benefit and lesser short and long-term complications, better anatomical and visual outcomes, and limited difference in the net cost. So therefore, the original ranibizumab, the gold standard anti-VEGF, scores. Innovator ranibizumab has demonstrated a well-established efficacy in RCTs with long-term data in 7 indications over 18 years. And the rapid clinical outcomes with innovator ranibizumab are sustained up to 5 years and are achieved with substantial reduction in injection frequency over time. Interchangeability is a vital quality for biosimilars to possess, which requires additional evidences to prove that the studied molecule produces the same clinical result as the reference product. Standardization and stringency in biosimilars approval process is need of the hour, and plethora of evidence plus high patient offering gives high cost benefit ratio with innovator ranibizumab. So counsel your patients well to make an informed choice. Do it right the first time. We don't always get a second chance. Thank you.
Thank you, Saurav, for this detailed presentation on ranibizumab. What we'll do is, because there are total of 4 talks. One talk is on ranibizumab. We'll have discussion now, and rest of 3 talks, I'm presuming they are primarily on ranibizumab. So we can have combined discussion on ranibizumab. So, Saurabh, you presented everything in favor of the innovator. So for you in your practice, you don't use biosimilar at all?
No. So I had to incorporate biosimilars because, again, some of these things are new, the cost calculator and all. We have not used that to see.
No, the reason I'm asking is, patient in our country will leave everything to you. Patient will ask, Doctor Sahab, meri aankh ke liye kaun sa acha hai? So you advise innovator or biosimilar?
So if there is no financial...
Because if you give him options, so he will say, Doctor Sahab, kaun sa aap bata do. Wahi puchte. I don't think the patient will go strictly by the cost only.
So if the patient is affording and there are no financial constraints, and if the patient happens to be a panel patient, or the cost is never a consideration, then of course I would like to go for the patent molecule, because I would like to have my good night's sleep. That is what I tell everyone, I mean.
So biosimilars give you sleepless nights?
No, I mean, in the sense, when they started out, we all know that we've had our share of issues with various. We used to then go after which lot number.
So meaning thereby, if it's a VIP, you give original, but if it's a poor patient, you give biosimilar.
Not really, sir. So it's all a question of affordability, I think. If the patient is affording, and can afford, or if the patient...
He can afford anything.
Yes. So I would not think twice. I would just go for the patent molecule, because you see that it's a time-tested, drug, and why would I not want to give him, the patent molecule? I mean, it's a no-brainer, I think.
I agree. The reason I still prefer innovator is not because of these reasons. Why I still prefer? Because despite the promise of economics by biosimilars, that has not happened. You see, even today, what I say, old is gold. Apart from safety, which you very rightly said, sleepless nights with biosimilar may be slightly more than innovator, and efficacy, I think they are reasonably good. But the issue was of economics also, because the reason of economics is assuming more importance, because if patient does not come for regular treatment, the efficacy or the treatment effect suffers, because then he will come SOS or PRN. So here lies our counseling part. With the schemes now which are available with the innovator molecule, if you calculate without this calculator also, it is economical. It is economical. The reason is, although you see biosimilars, the profit margin for the doctor is very high. There is no doubt about it, because the MRP is very high. But forget about those things, about doctor's profitability. The innovator molecule still is gold. Like you say, old is gold. So I 100% agree with you on that. There's no doubt in anybody's mind. You see, biosimilars came with a bang. They got approval in US also now. India also, DCGI, there are more than 5 biosimilars which have been approved. But purpose of biosimilar entering was that it can be blindly given to anybody, which is not happening. Total cost to the patient is still very high, very high. So if that comes down to half level or, one third of the level, then I would not hesitate. But if that does not happen, then obviously because of, the second slide of yours, largest trials, largest molecule, largest patient years, then that goes in favor of innovator.
Also in the COVID era, I would like to add that, we came across, certain things that, with the vaccines we learned that, there are things known as adjuvants in vaccines. So like that we have, excipients in these drugs. So what the excipient can do, and I think in the past, whatever episodes of problems we've had with biosimilars, it was linked to sometimes even the rubber which was used to make the stopper of those vials. I mean, a lot of investigation went, then the company went back. I mean, I wouldn't like to name them, but,
those
so
actually are nothing to do. You see, the problem with not the drug, it's the ultimate approval.
Yes.
Yeah.
So, but we are injecting whatever is given to us in whatever packaging is given to us. So, when you come across biosimilars, so again, there's an attempt at cost cutting, because, that is what they want to do. They want to reduce the cost, maybe of manufacturing or whatever, but it really, was a, kind of a revelation that, these factors can play an important role, in causing inflammations, and now we know of ADAs and anti-drug antibodies and all those things.
So let me ask, you see, for the sake of how many in the audience, or maybe Ajay included, me included, use biosimilars with as much confidence as innovator? Just show of hands that who are in favor of biosimilars and who are in favor of innovators. So I think, by and large, it's a divided kind of house that people, want the cost to come down definitely. And that's what you see, what I was saying was that if I inject today Accentrix, the cost is much less than if I inject the other biosimilar. Cost to the patient I'm talking.
Right.
Ajay?
Yeah, so I know, Saurabh, it's a very difficult question what Dr. Lalit asked you, and sitting in this particular session to answer that which one you will choose, innovator for a VIP versus biosimilar for a non-VIP. But I think what he brought out was that if you calculate the overall cost in the end and look at the schemes which are being put forth by the company, it works out equally efficacious and cost effective in the long run. I want to bring out 2 points. One is interchangeability and second is effectivity. One of your slides you showed the effectivity of the molecule of biosimilar can vary from 26% to 212%, which is very interesting. When you compare the effectivity, you compare it with the innovator molecule, and the innovator molecule is considered so almost 100% effective if we consider that. That means there is a batch-to-batch variability of the biosimilars, of effectivity of the drug, if certain batches are tested. And same ranibizumab by different companies can have different effectivity. The problem which we are facing in a lot of parts in the country is patient goes for the CGHS panel and they says, ye razumab le jao. Supposing some other drug gets approved, they say ki ranibizumab chahiye na, doesn't matter, you take another company's ranibizumab. So when we inject and the patient gets us a vial, we have to inject ranibizumab, it may be any company. So is that permissible? Do you follow it, or do you insist on a particular biosimilar if you ever use biosimilars?
Yeah, so I mean, so sometimes we can't just do anything about it, because if it's a panel patient and that particular, a different drug is there on the panel, approved or whatever, or available, then I don't think we can say no to the patient. We would have, and if it's an approved drug, of course, we'll have to give that.
So I think the answer to Ajay's your question is that I tell my patient that it is at your risk I am injecting.
Yes.
I will get it, because I recently had one doctor lady who brought one biosimilar in a pouch by herself. So I said, at your risk I am injecting, but otherwise I am not very keen. So that you have to tell to the patient that why. You see, I agree. Today is in this era of generics, you cannot actually write. You have to write ranibizumab in bracket. You may write Accentrix or any brand, but that you have to talk to the patient.
Yeah, so I think it's important for as a take-home message that whenever you are interchanging between molecules, it's important to communicate to the patient that ranibizumab, if the patient earlier had an innovator molecule versus a biosimilar, there can be differences of efficacy, as well as what he brought out is batch-to-batch variation of excipient. There can be reactions which we have seen. Over the period of many years, we have seen that the innovator molecule has been standardized and the reactions are far less as compared to the biosimilars.
But Ajay, let me tell you, this interchangeability is still a dilemma. Interchangeability is still not allowed, I think. You can't substitute, suppose you are injecting, say, Rani eyes vis-a-vis Razumab vis-a-vis this, because it's not only the Ranibizumab, but a lot of other things which may play a role in the ultimate outcome also. So even in the wider perspective, interchangeability is still a question mark. It's a question mark. So thanks, Saurabh, for bringing out this an ultimate message. I think should be that old is still gold. Old is still gold because of the number of years it is there in the market. Like you said, 18 years in the market means big. So we'll move on. Anybody else has any question for Dr. Saurabh, or he can ask? If none, I think we'll move on now to our guest speaker. I think he is online. Welcome, Dr. Chronopoulos. Dr. Chronopoulos will be talking to us about the changing treatment paradigms with durability and drying. You see, this was one comment I made in the beginning only, these two Ds about, because patients are concerned today about repeated visits, and they actually sometimes get fed up of repeated coming for injection and repeated consultation, repeated OCT examination. So what they want is a long-term relief. And we know that, new generation anti-VEGF agents, Brodusumab and other agents also, they are today working for, more than 2-3 months also. We talk of Q16, Q12 very commonly. So let's hear Dr. Chronopoulos from Germany. Welcome, Dr. Chronopoulos.
Yes, good morning. Many thanks for having me as a guest on your wonderful meeting. I will be talking today about the changing treatment paradigm with durability and drying in AMD and DME. This is the necessary disclaimer. Now, we know that the subretinal fluid, the fluid in general, is very important in the treatment of NAMD and DME. And most of our treatments and protocols today, they are based on our decisions, and they are based on the fluid and OCT, unless dictated otherwise by the health insurance. And we know that the longer that the fluid persists and the longer we have fluctuations, this is translated in less vision and worse results for the patient. So we need an agent that dries faster and better the retina in both diseases. When I'm saying that, we know all the percentages. There is a 70% of patients, this is true, who are untreated in the first year, with 50% of patients receiving less injections in a year. And in total, if this go on, then we have a 60% of non-adherence of the patients in total, and then you can understand this translates into worse results. Why I'm saying this and why is compliance an issue? This is the same for NAMD and DME. You see how busy the patients are coming back from consultations, receiving treatments. It has been estimated and calculated that in average, a patient is about 9 hours rest after consultation, in total 12 hours for the treatment, including the persons or the caregivers that are escorting the patients. So as far as AMD is concerned, we know that on the left-hand side, we have the majority of the patients. The majority of the patients, they receive less than 3 injections, or at least equal to 3 injections in a year. This is for the NAMD. And the question that arises, just by seeing the RCTs in the real world, you can see the discrepancy between the gain, the functional gain on the left-hand side and the right-hand side. How is it possible that we make it shift to the left as far as the AMD is concerned? And the same applies to diabetes. We know from the big registration trials for ranibizumab and aflibercept that we had a significant percentage of patients that were not completely dry. So we had about 26% in OCT and 74% in FLA with ranibizumab, and about 32% with vividin-vista. But even in the independent trials, the protocol I, for instance, or the protocol T, they have also showed exactly the same results, that we have a a significant percentage of patients that are not completely dry during the treatment in the first year. And this is how the real life looks like. We have about 50% of patients, if you look on the left-hand side of the graph, that received equal or less than 3 injections in a year for DME. And the same question arises also here, how we can make those results from the real world correspond to the results that we see from the registration trials with a good vision gain. Now let's see what brolucizumab is doing in AMD. We all know the Hogan-Harriet trial, which was the registration trial for AMD, and the comparator in this trial was the aflibercept. We know that function-wise, there was a non-inferiority for the drug, but the drug, brolucizumab, has shown robust effects in drying the retina. You can see the red numbers. We have much less patients having intraretinal fluid and subretinal fluid and sustaining that. These are the relevant graphs. You can see the gray line. These are both trials, the Hogan-Harriet trial, and you can see the difference, which is more pronounced in the Harriet trial, in how fast the drug is working in drying the retina. And not only that, you can see the graph, how fast the effect is reaching its ceiling in the brolucizumab group compared to the aflibercept. Of course, all this is translated in number of injections. You can see the graph on the top left side. You can see 2.4 injections to reach the 60th percentile. And you can see on the right side, the 76th percentile with 5.4 injections. So we're talking about almost a half for the effect of brolucizumab in terms of treatment burden. So less injections indeed. And if we look at the post-hoc analysis data, you see 3 columns. The darker ones that represent the brolucizumab, and the lighter ones represent the aflibercept, and the cumulative percentages on the right-hand side. You see that more patients reach dryness in weeks 96, which is basically 1 year. So brolucizumab achieves a faster and sustainable dryness in AMD compared to aflibercept. We make a small conclusion in between for AMD that more patients under brolucizumab achieve sustained dryness, and the time to first absence of IRF and SRF was significantly shorter in patients treated with brolucizumab. And if we take it up to a year, we see that 50% approximately of patients treated with the brolucizumab, they have a dry retina, a dry macula. Now, what's happening in diabetes? Again, we see the same trend that letter-wise, function-wise, there was non-inferiority of the drug, but the patients treated with brolucizumab, they had more patients with less intraretinal fluid and less subretinal fluid in the retina, which is actually exactly what we're seeing also in the NAMD. You see the relevant graphs over here, and it's more pronounced in the Kessler and Kite studies, which were the registration trials for the brolucizumab in DME. And you see that the obvious difference in how fast brolucizumab is drying the macula. And not only that, we have also functional results, as I showed before, that more patients are having a dry retina compared to the comparator, which was aflibercept. And if you look at the top of the graph, you see the obvious effect. We receive better results, better drying with less injections. Take one example. The left-hand side, you see week 100, we need 11 injections of brolucizumab and 15 injections of aflibercept. And of course, there are more patients treated with brolucizumab that achieve at the end of the 100th week, which is 2 years, they achieve a dry retina. And obviously with less injections. You look at the right-hand side, the Kite trial, we have at the end 15 injections with aflibercept and 10 injections with brolucizumab. Now, if we take this under consideration, is it possible to stop a treatment? This hasn't been indeed investigated a lot or at all in the current trials, but indeed it's positive. Indeed, it's possible. We take one. There is only one trial that has looked actually in this question, which comes from Switzerland, and these were patients treated. These were patients from the registration trials that were observed after the end of the trial, which means after 2 years, and you can see the amazing results. We start with the baseline in both cases with the retinal fluid. After 2 years, the retina is dry, the macula is dry. And without drugs, between 2 years and 5 years, the retina is dry. So it is actually possible to even stop the patients from the drug. Now, as far as the registration trials are concerned, now let's take a look about the real world experience. We have, this was a patient, 81 years old, came into the consultation. You see the angiography on the top and you see the OCT on the right-hand side on the bottom. There is an obvious PED and subretinal fluid. The patient received 3 brolucizumab injections, and on the 4th month, came back for a follow-up. Everything is dry. The PED is almost completely gone. There is a significant increase in vision from 0.1 to 0.4. This prompted us to do a study and analyze all the patients that were recalcitrant to other drugs. How would they react to the newer drug? And all of those patients, they also had a PED. Now, we had 20 eyes treated in this study, which was published 2024, submitted 2023. And all of the patients, they had a heavy history before them. They had about 10 injections, and the patients were not happy. So what happened is that we put them on brolucizumab, and you can see on the 3 columns, the first one is indication of anti-VEGF when everything started. Then in the middle, when we indicated the brolucizumab, and at the end, how it ended at the follow-up, you see a robust gain of vision, and on the right-hand side, you see a robust gain in tissue. So the drug is really working. It is improving the retina significantly. And you can see an example here of a patient with a very pronounced PED with much of subretinal fluid. Left-hand side is when everything started. In the middle is when we changed to brolucizumab, and at the end, how good the PED is deflating and the subretinal fluid is really disappearing. And if you're thinking about PED, this is a space under the retina, which has a certain volume and area. We also calculated that, and there is about a 60% reduction in all this. Now, what about DME? Is it the same? Take a look at this patient. This was a female patient, multimorbid with type 2 diabetes and insulin, and all the risk factors not to respond well. Renal insufficiency, sleep apnea, hyperlipidemia, nicotine addiction, and things like that. So she came in the consultation. Both sides had a very nice cystoid macular edema. Vision was 0.3. Injected per label, 5 injections every 6 weeks. Came back week 24 with a vision of 0.8 and disappearance of edema on both eyes. This patient is straight also from the consultation. I saw him 2 months ago. This is the state of the retina on the upper side. Before every treatment, this was a treatment-naive patient. Injected 1 brolucizumab injection. He's still in the treatment. I just took the images to show what's happening just only with 1 injection, how the retina is smoothing down and deflattening. This is another patient, exactly the same. Saw him 2 months ago in the same consultation. Just 1 injection of brolucizumab, and the whole fluid is disappearing. This prompted us also to do a similar kind of study in real world. We analyzed primary and switched DME patients. We had in total 32 eyes in this analysis, which has been submitted but hasn't been published yet, has been submitted. And the patients that were treated before, they had ranibizumab in the history, they had aflibercept and dexamethasone in blood. So you can see again on the upper left side, the functional result. There's a robust gain in all groups and of vision, and a robust gain of tissue on the upper right panel. But the most important thing that comes up to the study is that for the first time, I'm not aware of any other study that's not showed this before, there is return and improvement of visual density in the retina and perfusion density, which means that the patients before they were monitored with the CTA before the treatment and after the treatment, we see an improvement in the retina, we see an improvement in the circularity of the fovea, and we see an improvement in total of the of the capillaries and the perfusion. You can see here the numbers in the left-hand side. You see the numbers before the injection. In the middle, you see the density of the capillaries after the injection. You see the difference, which is going up, and you see the increased circularity of the fovea after the loading dose. Now, of course, if we're talking about the aflibercept of the brolucizumab drug, we all know the dramatic launch of the drug back in 2019, 2020, and there are many colleagues that are questioning and are still reluctant because they think that the drug will increase the probability of having an IOI. Now, if we look carefully at the data, it would take the first publication of those cases. We had 10 surgeons in the United States with 12 patients, and they all have been treated before with 2 to 80 injections, and they showed an IOI 30 days after the treatment started. But if we look exactly the numbers, we see that there were, from all the cohort, there were 3.3% of vasculitis and 2.1% of RVO, and of those patients, we had less than 1% of vision loss with associated risk of 0.6. Now, interestingly, also the patients that had IOI then continued treatment compared to the other groups. There was a drop rate which was the same in both groups, actually. And if we take studies have been conducted later on, for instance, the study from the group of Marconi, for instance, they reported 0.4% of retinal vascular occlusion as an IOI. A study of Marcos Arbit, for instance, reports an IOI percent of 1.2 and an arterial occlusion of 0.2% with no retinal vasculitis or panuveitis. And there is also a very interesting study from India, the VRSI study, which reported an incidence of IOI of 0.8%. As a take-home message for my talk, brolucizumab is a very effective and stabilizing drug for NAMD and DME. This is the only drug with the fastest fluid resolution in the market, and faster. This means faster improvement, function improvement, and faster reduction in treatment burden, as we have seen also from the registration trials. But I'm seeing also in my practice that the patients, they need lesser injections and they have better results, and it's also possible to wean them off the treatment. Thank you very much.
Thank you, Dr. Chronopoulos, for confirming what we also believe that this is one drug which works very, very nicely as far as resolution is concerned. I believe that if there is a faster resolution and more resolution, then it should also translate into more visual recovery also. Although RCTs show that this is non-inferior, but the fluid, if it goes away faster and for a long time also, then ultimately these patients should do better in terms of vision also.
Yes, that's exactly correct. There was a discussion about 10 years ago that I happened to hear in the United States, and I think it must have been an ARVO meeting where they were arguing whether you can leave fluids in AMD compared to DME. And at that point, they said, well, yes, for the DME you can leave a little bit of fluid, but not for the AMD. And now we have reached another conclusion: the retina has to be dry, and the more fluid you have and the more fluctuations you have, the less probability that the patient is going to recover as much as possible in the long run. Having said this, it's obvious that and from the studies that I've shown you in this talk, it's obvious that there is an obvious issue with the number of injections given to the patients every month and the number of injections that they need every year. As all things started with ranibizumab, we're seeing in a horizon of about 11 injections a year. This has been brought down now to 7 or 8 injections, which translates automatically to less treatment burden, which is more friendly for the patient, and they do reach better results.
Do you believe in starting treatment with brolucimab or only patients who are resistant or recalcitrant?
That's a very nice question. Very much, many thanks for this question. We had a dramatic launch of the drug, as you know, 2019, 2020. And as with every drug, we're a little bit reluctant at the beginning. And we tend to indicate the new drug in patients that do not respond with drugs that we actually know quite well how to handle. Now, this is how I started my treatment with the drug. Currently, and having seen all those results in my consultation, I start right away with brolucimab.
Yeah, I think with passage of time, the confidence level is increasing. I just heard a talk by another speaker in the morning session. His first agent of choice today, considering the effectivity, drying, as well as the cost also because the frequency of visits go down, is today brolucimab. Ajay, your take?
Yeah, so nice presentation. I have one question. You know, there have been fluid studies which have shown that a minimal amount of fluid might actually be protective, but Hawk and Harrier particularly showed that even little bit fluid actually in the long run can be counterproductive to the visual recovery, and maybe because of the drugs which were used in the fluid studies were not as potent as brolucizumab and therefore were not able to dry the macula as much as what brolucizumab does. But there is a difference of opinion. Fluid study says if we leave a little bit of fluid, it may be better, versus Hawk and Harrier saying that you leave this fluid and it will actually not result in better visual acuity. What is your take on that?
Yes, this is also a very interesting and nice question. I can also answer. There have been other studies that have shown that the fluid matters. So if you leave fluid, then at the end, the long run, you will have less vision. I think, from my experience so far, having fluid is for me, from my experience so far, for AMD, fluid is not a good parameter if you leave fluid. From my opinion, you can wean off patients with DME just with a little bit of fluid, which have reached a very good vision, 0.8, 1. We have seen patients with 1.2 having a little bit of fluid. You don't want to do over treatment, but in overall, if I start somebody and I see those robust results, I tend to try to dry out the retina.
Dr. Chronopoulos, I firmly believe that no fluid is good. No fluid is good. You see, persistence of a fluid means defeat of the drug. If the same fluid can be dried by brolucimab or Pagenax, so what is the big deal about it? I do not believe this concept that some fluid is good for retina and some fluid is bad. I agree IRF is the worst kind of fluid, but that does not mean you allow SRF to persist. Because if there is a patient who has SRF and if I can get him dry with one injection of brolucimab, then why not?
Yes. Fluid is, I see it exactly the same way you do it. I feel disturbed about seeing fluid in the retina. So if I have the option to do it, yes. But some patients, they do get fluid. In those cases, of course, the drug will work up to a certain extent. You cannot dry everybody, all patients, with the same drug. This is true because every patient is different than the other, and you have to take into consideration more other parameters. You have also a magnificent laser in the clinic that you can also use. The focal laser, at least in diabetic macular edema, is still a valid option that you can use.
And in cases where the patient is not... I agree, laser can be used, so many other things can be used, but persistence of fluid, if it can be dried by another agent, I think it's the defeat of the previous molecule. I think we'll go on because we have 2 more lectures and we will request you to please hang on, and because we may have some good discussion coming out of the next 2 presentations. So I'll call upon Dr. Sen Gupta to tell us about breaking the barriers.
And we want you to stay on online so that any questions come up for you, we'll request that they are asked for you. Thank you.
So, Sengupta, what barriers you want to break? Mike?
I think I'm audible now. Very good morning, everybody. And so, we'll, so what do you think is the biggest barrier in management of neovascular AMD today?
Just to my knowledge, two only. One is all of them don't respond, and secondly is the durability, because these two things put off most of the patients.
Right. So the biggest barrier really is giving injection after injection and still not getting desired responses. So before I go to my talk, I'll perhaps do a couple of comments on the previous lectures. So Dr. Luthra presented on and we had a lot of discussion on whether you can actually move from one to the other and biosimilars. So though Indian companies are coming up with biosimilars and there are so many in the market, we are not seeing enough rigor in terms of clinical trials, and companies are not doing trials because the DCGI does not demand those, isn't it? But I think as physicians we need to demand clinical trials and only then use those drugs in practice, because if you say it works, it may work, but from a head-to-head basis, have you actually seen in the real world whether it's actually working or not? Because we are going to see a huge barrage of biosimilars, and how do you decide? And so the Indian companies need to understand that scientific rigor is very important, and we as clinicians today want to see data and trials. So we are seeing trials in pilocarpine, we are seeing, as in the Indian pilocarpine, we are seeing trials with Indian atropine. We are also seeing clinical trials with ranibizumab. That's only one company has done it, but all of the others need to do it. This, the second thing about fluid and leaving behind fluid, I think, is tolerating fluid would be the right word, and not leaving behind fluid. So the concept was, what do you do when you're giving multiple injections and the fluid is not going away? There's nothing much you can do.
This is a very good word.
So you need to tolerate it. But then these concepts are getting outdated with brolucizumab now, or with the stronger drugs, because tolerating fluid with brolucizumab is not really okay.
That's what I said, Sengupta, because I was disagreeing with Dr.
Exactly. So
that is a defeat of molecules. Suppose I am doing A, B molecule and fluid is there, vision is also maintained. Now inject brolucizumab, this fluid goes away. So that means these are defeat of the drug, not the...
Right. So I'll show you a couple of my cases, and so I'll quickly share some clinical trials, and then how do I actually import all of that into real practice is what we'll discuss, and hopefully we'll break some barriers, and so some necessary disclaimers. And so we know that neovascular AMD is much on the rise now, and this is the very large study done at Shankar Nethralaya which showed late AMD, that is neovascular AMD, is affecting about 2.5 to 3% of the aged population, and the absolute numbers are relatively high. And so, Dr. Luthra also mentioned about the Luminous study. So if you give loading doses, the vision actually improves. So there are 54 letters, really means 6/24 vision. And if you give loading doses, the vision goes to about 618, sometimes 612. If you don't do loading doses and you give the same number of injections over 1 year, you do PR and you say give 1 injection every 2 months, the patient will drop vision. Right? So if you give 6 injections but with the loading dose and space it out, patients will gain vision. If you give 6 injections but don't do the loading dose, patients will lose vision. And so, the unmet need from a physician's point of view, so this is the PAT survey which was done by the ASRS and it happens every couple of years, clearly shows that physicians also want reduced treatment burden. Nobody wants to keep injecting again and again. And when you actually ask patients and the physicians, so patients prefer fewer shots, even if they lose some vision. That's I think very profound, right? Patients are okay with losing perhaps 1 line of vision, but they don't want that many injections, and we need to cater to that. And physicians, of course, also want fewer shots, and the commonest option that people chose was combination of B and C. Patients also want fewer injections, doctors also want fewer injections, but at the cost of losing vision, so that's really defeating the purpose. This was in 2018 before brolucizumab came into the picture. So the ongoing challenge really, or the real barrier, is to maintain treatment efficacy while reducing clinic visits, as well as the number of injections and thereby the cost. So, so as we've been talking about, so, why does brolucizumab reduce the number of injections? Is because it's a really small agent. So it's a single chain antibody fragment. So we know the FAB fragment, the FC fragment, and there is, something which is sitting like a cherry on the cake, on the FC fragment, which is actually the single chain antibody fragment, and that is, so scientists have managed to just about isolate the active part of the whole jigsaw and give it to us in a packaged form, that is brolucizumab. So it's a 26 kilodalton, it's a really small molecule. So you can pack 6 milligram of drug into that 0.05 allowance that we have, whereas aflibercept can pack 2 milligram and ranibizumab can pack 0.5 milligram, right? So there's a huge dose advantage there. So, so Dr. Chronopoulos has told a little bit about the Hawk and Harrier. It was these, these were global trials, and India was actually part of the Harrier trial group. There were some centers in India which have actually recruited about 40 patients in the Harrier trials. So the key inclusion quickly was, of course, there was active neovascular membrane. And this is what was done, and I think this is what, if we can actually adopt this in clinical practice, it's not very difficult. Let's look at what was done. Was a loading dose of monthly for 3 months was given, irrespective of how the OCT looks like. Right? So many of us don't give injections at 1 month because we say, oh, this looks great, this looks normal, why do I want to re-inject? But then the disease is relentless, it's going to keep coming back. So monthly for 3 months. After that, at 8 weeks, that is at 16 months, 16 weeks or about 4 months, you do an assessment and you see if there is fluid, you re-inject. If not, you keep sort of the interval of about 3 months. And aflibercept, of course, was given every 2 monthly. So overall, if you look at the primary endpoint, which is that arrow, the dark arrow at 48 weeks, if you see aflibercept, according to the protocol, required 8 injections, while brolucizumab required 6 injections, and in the real world, we might actually come down even 1 more, right? So even in the clinical trial, the number of injections was 2 fewer, right? So we are talking about breaking barriers. So this is already, sort of incorporated into the clinical trial design. And so this was when you re-inject, right? So I think this is very useful for a clinical perspective in daily practice as well. So if patient loses one whole line of vision, so they were 612, now they became 618, you are going to re-inject. And the second thing is if the fluid is increasing, so they say more than 75 microns, but roughly it's about 10% fluid increment from the previous visit if there is. And if both are there, you definitely go and re-inject. And so this is sort of the matrix, and there's a lot of things happening there. But this is overall the treatment matrix which were used in this these clinical trials, and these are the consort diagrams where so the Hawk had about 1082 patients and the Harrier had about 743 patients. So this is the baseline characteristics, and without going into nitty-gritties, let me tell you that this was about most patients were white, and there were more women in this, and they were about 75, 76 years old. All these patients had a baseline vision of 618, had macular thickness of about 470 microns. All of them had subretinal as well as intraretinal fluid. So this is typically how an OCT in the clinical trial patients look like. So do you think your patients look like this? Now, most of our patients actually do look like this. Maybe they have slightly lower vision. So then all that the clinical trial says is what we can actually use in practice. So the primary endpoint, of course, was vision, and OCT were the secondary endpoints. So when you look at vision, they were very similar in terms of change in vision or improvement in vision. And how much did the vision improve? It improved about 1.5 line. So patient starts at 618. A lot of patients went to 6/12 parts. So if your patient actually is starting at 6/60 or 6/36, you should improve, expect patients to improve about 6/18 partially, and don't over expect and don't, sort of don't over promise. And so do all patients improve, and by how much? So if you look at 3-line improvement, that's a lot of improvement, a significant improvement. About 1/3 of the patients improved to that level as well. When you look at OCTs, and Dr. Chronopoulos has also showed us this, what we really hate, or what the retina actually hates, is fluctuations. So if you look at the graph at the bottom, the one in green is aflibercept, and you can clearly see there's a lot of seesaw patterns, at least in neovascular AMD. And that is what is not good. So if aflibercept was lasting for 2 months, you would not have seen that kind of effect. So in neovascular AMD, we are commonly seeing, most patients require repeat injections about 6 weeks right at the beginning. So that fluctuation is something that we don't want, and you can clearly see brolucizumab is giving us almost like a flat line. And coming to OCT, and we were discussing just now about which is better, which is not. So so this is if you see those black squares, they are where patients lost vision. So the one on the left is intraretinal fluid and intraretinal cysts. At 12 months, that is the third one, the first box on the left, the third graph. And it's very, very large. Almost 50% patients lose vision. The black is lost vision. So lose vision if there are intraretinal fluid and intraretinal cysts. So that clearly shows that intraretinal fluid is the biggest is the biggest one. But neovascular AMD starts below the RPE. Fluid first goes into the subretinal fluid and then it percolates into the intraretinal space. So obviously if there is fluid in the intraretinal space, it's the worst one. And if you look at the right, on the box on the right and the rightmost one, that is at 12 months, presence of PED or persistent, persistent PEDs or pigment epithelial detachments also indicate that vision is not going to improve as much. So a lot of patients actually continue to lose vision. So what we really want to do is entirely dry the intraretinal fluid. We want the PED to go down as much as possible. Maybe some amount of subretinal fluid is okay and we could tolerate that. So, the Hawk and Harrier trials clearly showed that, fewer patients in brolucizumab had intraretinal fluid, and also fewer patients in brolucizumab have subretinal fluid. So the Harrier trial, some Indian patients were in this. About 17% patients had persistent SRF, whereas in the aflibercept group is almost double of that. And when you look at PED flattening, this is also what we want to have. Again, brolucizumab was able to flatten PEDs more than aflibercept. And the real idea or the barrier was too many injections. So how many patients are able to maintain one injection every 3 months? So it's about 56% in the Hawk and about 51% in the Harrier. So more than half patients are able to do well with once in 3 month injections. That's like 4 injections a year, which is like really good. We never had that before. And almost all of them will maintain this at 1 year. And again, almost all of them, that's 3/4, will maintain that at 2 years. That's actually, if you do your calculation, you will see that brolucizumab can do well with about 8 injections over 2-year periods. And aflibercept will need about 12 to 13 injections. So, that's a very large number of injections. So overall, so brolucizumab was non-inferior, at least in clinical trials. It was long-term maintaining vision better, and it was definitely better in controlling fluid. Let me quickly show you some of my cases. So this is a fundus photo of a lady with, so you can see the little bit of hemorrhage there, and this is how the photograph, the OCT looked like at baseline. As you can see, there is very minimal amount of fluid, but there is a membrane there. And in these cases, I generally choose ranibizumab as well. So monthly for ranibizumab, vision improved to 6/9. And then, this is typically how we do with ranibizumab, where we do treat and extend. So first repeat injection was given at 6 weeks, the second was given 8 weeks out, the third was given 10 weeks out. That's 2.5 months. However, she was scheduled for that 10-week injection, but she presented with drop in vision. And this is generally what you will have. When you're trying to extend, that 10-week is the biggest barrier. If you're able to extend beyond, you will be able to do well with that. So this is, that lake of fluid which has come back. And the whole question is, do you tolerate this? Or do you just say this is all right and I'll continue with the same drug, or do you shift? Right? So right at the beginning, saying I'm going to leave this alone is not okay. Right? So we need to do everything to dry it. And if it's not drying, then you say, okay, fine, I'll tolerate it. Right? So this is something that you don't want to tolerate. Right? So at 10 weeks, this is on extension. This patient has already taken 6 injections, 5 injections, including a loading dose. So she preferred ranibizumab again. She said, no, I don't want to do. After 1 month of ranibizumab, you can still see that fluid there. So again, do you tolerate this is the whole question. Not yet, right? I want to dry it more. So then you actually shift to brolucizumab.
You can finish in 1 minute.
Yeah, I will finish. I'll quickly show you. So you can actually don't tolerate this fluid. I'll show you one last case. So these are all you can quickly see they are improving with brolucizumab. Yeah, and this is case who had bilateral AMD, which is not very common, and we can see how brolucizumab affects that. So this is the right eye of the patient on 2 different views, the horizontal and the vertical view. You can clearly see fluid there, and at 1 month, if you see, it's as if nothing was there, right? And then at 2 months, again, so this is a loading dose. After the loading dose, patient has done well, and at 6th month, he has started to get fluid back again. So the injection has lasted for 3 months, and he is doing well once in 3 months now. This is the other eye. Again, you can see, there is a membrane. There is intraretinal as well as subretinal fluid here. And on the right, this is 1 month post-injection, and 2 months and 3 months post-injection. And then, so he's relatively doing well. So these are after loading doses on the top right. And this is at 5 months. That is 2 months after the loading dose. He has gotten a recurrence. In the other eye, he had got it after 3 months, right? So what is the difference is in the right eye, there is not so much intraretinal fluid. In the left eye, there is much more intraretinal fluid. So at baseline, if there is a lot of intraretinal fluid, we could expect patients to do well every 2 monthly. But if not, if they don't have a lot of intraretinal fluid, they may do well once every 3 monthly. Whatever it is, the number of injections are definitely going to be lower. So, some information about brolucizumab. Thank you so much.
Thank you. I think for paucity of time, let us go to the next presentation by Dr. Indu Singh. She's going to talk on my experience with brolucizumab and DME. And in case we have questions, we'll come back.
Dr. Indu has a lot of experience of using what I call this wonder molecule, brolucizumab, and maybe she uses as a primary treatment in a lot of her patients. No, Indu?
Yes, thank you. Good afternoon, everyone. Now we moved post-noon, and so I'll be talking about my experience with brolucizumab in diabetic macular edema. Lots have been said already in the last 3 lectures, so let us just move on to the fact that every other person in the middle-aged group is a diabetic, and we have tried so many options. We've done surgeries, we've done, given lots of injections, and seeing the older generation of anti-VEGFs, we know we have not succeeded fully. We have to interchange, and since the time I started using brolucizumab, and yes, because of its penetration deeper, we have all noticed that it leads to more drying, and obviously then, better saving these eyes. We've studied extensively in the Kestrel and Kite study, and we know that we've already talked about it. And now, straight away, I just want to share some of my patients. And now this is one patient who, we all know that diabetic patients, they have comorbidities, and they have nephropathies, they have hypertension. Till we are aware of all these problems and we just keep giving injection, there'll be no end to it. We'll not be able to stop giving these injections and treat them properly. So this patient who had nephropathy, and as we know, once the kidney status is compromised, the HbA1c starts going down. This patient has cataract also. And let me show you, after giving 3 injections of brolucizumab, there is some semblance of the normal retina that we are able to see. Of course, there is still cataract. So what is important here is that we have to treat the patient as a whole. It's not AMD. This disease is, it has various other problems. You have to look at their HbA1c. Let the patient be treated by a physician before you start your treatment. Now, this is another patient. I do OCT angios in all the patients, and if you look at this, there is a hard exudate here and a thin ERM. Now, this is a patient who has HbA1c of 9, and with 2 injections, look at the difference it's made. The ERM, of course, is still there, but the hard exudate has completely, it's in the process of drying, and the HbA1cs come down from 9 to almost 7.2. So look here, the OCT angio is looking so much better. Another patient, uncontrolled diabetic, 9 HbA1c, and if you look at the line scan, then you can only look at the macular area, but if you want to see the whole retina, then it would make more sense to use these, brolucizumab-like molecules, because, everything, all the leaking areas all over the retina, they get influenced by this. So after 2 injections, see, this is how it seems, and even the retina is so much improved. Of course, these patients are still under observation, and they are still being treated, and the HbA1c has gone down from 9 to 7.4. 12.2, uncontrolled diabetic, and there are all leaking places here with lots of exudates, subretinal fluid, intraretinal fluid, and 4 injections of brolucizumab. Look here. If you look at this OCT angio, you'll notice that the leaking aneurysms are all gone. And likewise, from 12, the HbA1c has come down to 7.2. What is actually helping us here? Of course, a good molecule, and also the fact that we are treating the patient as a whole. So another one, 12 HbA1c, and this is again an uncontrolled diabetic, 2 injections. The retina looks so much normal, and from 12, in the 3 months that we have treated this patient, the HbA1c has come down to 8.5. You'll be surprised when you look at their HbA1c, all those patients who visit us every day. Another patient, around 11 HbA1c, there is this hard exudate, and after 4 injections, we have a fluid there, but at least the hard exudate is gone, and the HbA1c is still 8.4. And once you take it down to about 6.5 or so, there is a lot of chances of your stopping the treatment. Another one, now I'll be showing you where I gave just 1 injection, and most of the time you see situations like this when there is leakage all over the retina and in the macular area, of course, and just after 1 injection, the central area has become better, but still the patient is under treatment. Another one, look at a huge area which is totally leaky, and even the submacular fluid is there, 10 HbA1c. After 1 injection, the leakage area has come down, the macula has dried up a little, but yes, the treatment has to be continued. Another one, 10 HbA1c hard exudate, and after 1 injection, there is some semblance there of the normal macula, and there is this hard exudate which is resolving. If you look at this slide carefully, there are different pockets of fluid all over this place and large loculi in the macular area, 9.2 HbA1c, and after 2 injections, look at the OCT angio, you can see all cleared up edema. The macular area still has those large loculi, but this patient needs more treatment, and he's still under treatment. Now, this is a patient where we are dealing with a diabetic nephropathy also, and we've noticed that brolucizumab acts very well in these patients who have cracked up to 3 or 4. So after 3 injections, the patient looks better, the vision has improved. Now, this patient has 9 HbA1c, and if you look here, this is the leaky area, and after just 1 injection, the leaky area has become better. This is subretinal exudation and lots of intraretinal fluid, and 10.5 uncontrolled diabetic patient. After 2 injections, see, this acts like magic if you treat the patient as a whole and also give this drying agent. 9.8% HbA1c. All of our patients, who are into this, either they have, other comorbidities, and we have to take care of their hypertension because these patients are mostly hypertensives also. So after 2 injections, this is how, as normal as ever. Now from 9.8, he's come down to 6.9, and these are the patients where you can think of stopping treatment and keep them under regular follow-up. 9 uncontrolled diabetic, and after 1 injection, the patient is better. This is another one, pre-treatment, about 9, and after 2 injections, the patient has, the diabetic macular edema has resolved. 9 uncontrolled diabetic, after 3 injections, he looks much better. Another one, now the edema, if you look at this OCT angio, the edema is here and here. And after 2 injections, see only the exudates remain. They are the last to go. But the edema in the center, the leaking area, is all cleared up. So this is another one where we gave injections and the patient has become better. Now this is, both eyes are the same patient. This is the right eye, the left eye, and there is leakage all along, and the patient was given 4 injections still under treatment, 2 each eye, and look at the way he is improved. The edema is so much better. This is the last one, uncontrolled diabetic, this is like a switch over from ranibizumab. And after 2 injections of brolucizumab, the edema is going, but the hard exudates still remain. So, ladies and gentlemen, let's consider the patient as a whole, not just eyes, and just take care of all the comorbidities of these patients. Dry the macula fully with brolucizumab and take care of the blood pressure. They mostly, this is what our physician says. They say, no, they have to be given antihypertensives because we are dealing with something which is, the CME can increase if you have high blood pressure, the patient. Thank you.
Thank you, Indu, and all the speakers. Dr. Chronopoulos, it is 5 minutes early. We are finishing because we started 10 minutes late.
But the tragedy of life is time is everything.
So in any case, we thank all the speakers with only one line that today small is powerful. Small molecule of brolucizumab is very powerful, and because of better drying, because of faster drying, because of sustained drying with less number of injections, there is a compelling evidence today that we should be depending on this molecule with lot of confidence. Thank you everybody.
And as Dr. Indu has shown that despite diabetic being considered as an inflammatory disorder, brolucizumab is very effective, and we are not seeing more reaction in these cases, so it can be safely given at least in the Indian eyes.
So Chief RP Center asked me about inflammation because because the Chief RP Center is asking about inflammation. The inflammation rate published, by the RCT was around 4%. But the real world data shows around 0.79%. VRSI recently published last month or 2 months back, only the entire survey by VRSI is in our data it's around 0.2%. So inflammation in Indian circumstances, somehow we are lucky genetically or whatever may be the reason, is not. The real world data as well as RCT, there's a total mismatch. Dr. Chronopoulos presented from Germany, he just presented 0.4% inflammation. You see, at the cost of not drying, vis-a-vis drying, cost of giving the best to the patient, vis-a-vis not. So here is a molecule which does not spare any fluid. So it is very, very powerful molecule. So don't tolerate fluid, inject.
In fact, what Phil Rosenfeld said is like the MAX 737 moment. When initially MAX 737 was introduced, there were a lot of accidents. Maybe the Indian data will show them that brolucizumab can be actually effective.
So with this, we conclude. Thank you so much. Thank you.